Hello, my name is Courtney and my chosen topic is attentional disorders, specifically looking at ADHD. ADHD is diagnosed when 6 or more inattentional symptoms or 6 or more hyperactivity impulsivity symptoms are present for at least 6 months to the point of maladaptive interference of a person's development. In young children, the effects of ADHD often result in troublesome behaviours. With clinical psychology, 2 common interventions for this is behaviour support intervention and medication. Professional guidelines advise to begin behaviour intervention prior to the medication. However, many young children are seen to be on medication as their only form of intervention. Regardless of the health implications these high doses of medication imposes, there is no opportunity to assess the benefits of behavioural treatments, nor is there room to explore the effectiveness of the combination of treatments. The current research has identified a gap in the literature whereby sequencing, dosing, and combining treatments in everyday settings has not been explored. A study done previously contrasted only optimal doses of medication in compared to intense behaviour support. This study presented no opportunity to assess children at different levels of intervention, nor did it explore the combination of each intervention. Another study addressed different levels of intervention. However, limitations were established as the interventions ran over a holiday period and there was no science as to whether the results would translate to everyday life. The current study addresses 3 questions. What is the most effective initial treatment? What is the most effective combination and sequence of treatments? And in the case of an insufficient response to the first treatment, what is the most effective second stage treatment? The current study runs across a typical school year. Children were randomly placed into either a behaviour intervention group or a medication group with a low dose of medication. Children were assessed according to ratings from their parents and teachers, and it was determined whether their initial treatment group was effective. Effective responses continued on the same treatment. If an insufficient response was determined, the child was re-randomized into either a group of a more intense version of the initial treatment or the alternate treatment was introduced. This table shows a reduction in 2 areas of problem behaviours. There was a considerably higher reduction in classroom violations by children receiving behaviour interventions. There was also a reduction in the need for disciplinary action for the same group, however, the results did not differ as much. The next table looks at sequencing specifically. So this table looks at children who were initially in the behaviour intervention group, however, met the requirements for additional treatment. The behaviour support, followed by a more intense behaviour support, showed a higher reduction in classroom violations. However, the behaviour support with a follow-up of additional medication was more effective in the reduction of disciplinary action. And finally, the children who received medication as an initial treatment, we can see that the most effective combination and sequence for a reduction of classroom violations and the need for disciplinary action was the medication followed by an increase in medication. Overall, the most effective treatment and sequence was an initial treatment of behaviour intervention followed by an addition of medication. Interestingly enough, this is in line with the professional guidelines. There was a large reduction in rule violations and a third of the group continued with no additional treatment for the entire year. It is also important to note the sequence because behaviour followed by medication sequence is superior over the medication followed by behaviour. And there could be many reasons that the initial behaviour interventions were superior. A standout one is that for the initial behaviour group, each child's parents also attended training programs and were provided with behaviour strategies. Also, behaviour interventions and training are often able to be implemented and adapted to a diverse range of situations. I believe both of these things create a more holistic approach to altering a child's behaviour, especially because interventions in this study ran across the home and school and in between parents and teachers. It could also be argued that the consistency of behaviour interventions versus the inconsistency of medication, which was only in school hours, may be the cause for the superior effects in the behaviour first group. Following this, parents who had children in the medication initially group did not receive any behaviour support interventions, nor were they required to attend training in behaviour strategies. This could mean 2 things. They were not equipped with enough information, training, or training to manage the problem behaviours in the home, which also correlated with the time when the child was not medicated. Or it could also mean that even if their child was re-randomized into a behaviour group, there was a reluctancy to attending the requirements of the additional treatment. However, I honestly think it's really important to have a look at the other side of the medication argument. I think that there is a potential importance for medication being an initial treatment. I think that this is in some cases very important when children are so hyperactive, oppositional, or lack the ability to hold attention, because these specific types of children may need the medication as a catalyst for concentration in order for the behaviour interventions to have a serious effect. In conclusion, we can see the best overall combination and sequence is behaviour intervention followed by medication. And at the end point review of the interventions, the most effective results came from children receiving behaviour intervention as an initial treatment. Let's have a look at strengths and weaknesses of the study. Being in a natural environment, the results show a true representation of a child's everyday life, and this adds clear validity to the study. Also, the effects of the re-randomization allow for several combinations to be explored. However, I do see more weaknesses in the study. With a small sample size, there is no way of arguing that the study uses a true representation of the population. Also, due to the fact that parents and teachers knew about the procedures, it could be argued that there was a bias or that the assessment of success was not accurate. Also, there is no way to assess whether the implementation of behaviour strategies in either setting was implemented and that it could be left to chance. Finally, it was fairly easy for parents and teachers to request additional treatments simply by saying the treatment was insufficient, and the researchers had no way of monitoring this. Moving forward, I think that the second re-randomization could be removed, and in the case of an insufficient response, the second phase could simply be the introduction of the alternate treatment. This removes the possibility that the combination was left to chance. Also, I think that in the future, a different method of assessment could be used. I would suggest a baseline assessment of the child's behaviours using a frequency behaviour measure, where target behaviours could be identified. What is a bad behaviour for one child may not be for another. Parents could report in a more simplistic way, stating an increase in target behaviour, no effective intervention, or a decrease in target behaviour. And the second stage of treatment could be implemented and done from there.